Good morning, everyone. Good to see you. Welcome to Mount Sinai. This is the third edition of our live case series, Treat Live. I'm sitting here with Dr. Ed Kim, my friend and colleague. I also have on the line a very special guest, Gary Siskin from Albany Med.
Hey,
How you doing,
Gary.
Gary?
Guys, good morning. Thanks for the invite to be here.
Good to see you. Without further ado, we're going to transfer over to room one. Dr. Patel and Dr. Bishay have a very interesting case for us today. I also want to briefly thank BroadMed AV for providing our AV support here for our live cases today. So, Rahul, can you hear me?
I can hear you. Can you guys hear me?
Absolutely. Why don't you guys go ahead and show us what we have for us today?
Thank you. So, to my left, I have Dr. Bishay, and to my right, I have Dr. Carlone. As well, because we can't obviously do these live cases. And obviously, our anesthesiologist. I think we have a great case today. I think it's really apropos. Best is next week. We have a interesting aneurysm. So I'm going to give it over to Dr. Carlone to go to his slides.
All right. I don't know if you guys can see the slides yet, but good morning, everyone. I'm Tim Carlone. I'm one of the integrated residents here. Great to be here this morning. Are you guys able to see the slides?
Not yet.
Not yet.
All right.
Here we go.
There we go. Now it looks like we can. All right. So this is just a quick introduction to this case of some superior mesenteric artery aneurysms. Next slide, please. So on the table, we have a 60-year-old woman whose past medical history is significant for cirrhosis, as well as thrombocytopenia. She initially presented to us after she had a screening CT for her liver disease and was found to have multiple SMA aneurysms. She did not have any associated symptoms. Her past medical history, important as I said for cirrhosis and thrombocytopenia. Surgical history is relatively non-contributory here. No known allergies, and she's on just sort of standard medications. Next slide, please. On exam, her exam is benign. As I said, she was asymptomatic. Lab results, normal renal function, and she does have some chronic cytopenias, as I mentioned. So let's get to the good part. There's a CTA that she had obtained that shows a couple of large SMA aneurysms, including one that is larger than the adjacent aorta. Next slide, please. So this is just a quick run through of the CT, and then I have a couple of still images to show. So as you see, as we come down through the celiac and the SMA, the celiac looks nearly occluded at its origin, and there are multiple SMA aneurysms. Next slide, please. So this just shows a couple of the largest of the SMA aneurysms. You can see that there's that one just sort of anterior and to the left of the aorta, which measures about 1.5 centimeters compared to the celiac level aorta, which is about 1.4. And then she has multiple of these tortuous collaterals in the area of sort of the pancreaticoduodenal arteries. Next slide, please. And so this kind of gives us a hint to the source of it. On the left, we have just a sagittal MIP of that CT. And I don't know if it projects quite well enough, but there's a very, very thin, basically straight down narrow channel at the origin of the celiac, which looks like median arcuate ligament compression. And then we have some coronal MIP images of the largest of the aneurysms. There's that large one that we saw axially on the CT, and then kind of multiple smaller ones within the pancreaticoduodenal arteries.
I can't hear it.
Next slide, please. So in summary, we have a 60-year-old woman who has multiple incidentally identified SMA aneurysms, and sort of the significant piece here is that she has cirrhosis and thrombocytopenia with concern for sort of increased risk of bleeding and rupture. These originate from multiple proximal SMA branches. And then the largest is the same size or slightly larger than her abdominal aorta. And then the likely sort of etiology of these is she has median arcuate ligament compression and she has dilated collateral vessels supplying the celiac trunk. So we discussed the treatment options in depth with the patient, and our goal is to embolize at the very least the largest of these aneurysms, and then we'll get a better sense angiographically of what else there is to treat. Anything, Griffin?
Great. Nope. So we can go ahead and kind of talk about what we did so far in terms of catheterizing the SMA.
Yes, so we put in a Sarah. So we decided to go radial. So we have a 4-4-5 slender in the left wrist, and then a Sarah catheter down into the SMA. And so this is our first angiogram, and you can see. You guys can see this. Hopefully, you guys can. Can you guys hear me?
We can hear you great. Yep.
Yeah. Yes, perfect.
Okay, perfect. All right, so you can see this is the SMA angiogram, again, showing multiple, some larger than other aneurysms off sort of the collateral pathway back to the celiac artery, which is being revascularized by these collaterals coming off the SMA. We were hopeful that some of these would be coming off the same trunk, so we wouldn't have to catheterize multiple branches. But we figured we'll start with the big one first and then sort of work our way around. And so here, you can see we basically got into the aneurysm. We were able to get to the outflow of the aneurysm. We did a run on the other side, which is basically, whether it's the anterior or posterior division, I'm not really sure, of the IPDA. You can see this is basically, there's no real aneurysms off this one. And so we basically pulled back, did a run from the aneurysm itself. Again, there's no other aneurysms coming off this vessel. There's really no other outflow vessel as well. And so where we are now is basically back into the outflow of this aneurysm, and we're just going to coil our way back. So I guess the question for the audience and the panel is, so how do you guys manage this? Do you guys consider revascularizing the celiac? Do you have a size criteria for treating these?
So a question that I have for you, Rahul, is we know that we see this type of aneurysm very commonly with celiac stenosis, and a lot of this is related to dilated collaterals. And so you're likely going to address the largest one first, which is what you're showing on the screen. But what's your concern for removing some of these collateral vessels and providing flow to the celiac? And would you be able to maybe tell us a little bit more about how you're going to determine whether the flow through the retrograde flow through the celiac is adequate?
Yeah. So I think basically we're going to do them one at a time, right? So I think as we take them down, we're going to basically check the flow. In my experience in taking these, you tend to be able to take them down without too much issue. I've never seen someone infarct their liver or their spleen from it. The celiac's very well collateralized, and so you can do it. So I'm not really terribly concerned about that. So this that's fine.
Just let it go.
Yeah. So this
I agree
is
with that.
an embolized. Yeah. Sorry, go ahead.
I was just going to say the collateral flow in that area is robust enough that I think the priority in terms of addressing the aneurysm is you can get away with it and not worry about the collateral flow. I agree. There's enough there to account for flow to the liver that you don't need to worry about it.
So Gary, what's your Rahul, either of you, what's your threshold for embolizing
Pull the micro
visceral
back a little bit.
aneurysms?
I would say
I'll let
that
Gary go first.
I'm thinking to myself that the first thing that comes to mind here is roughly around 2 times the size of the native artery is when I start to think about it. So, you can read different things. You can say maybe 2.5 times, but to me, an aneurysm that's more than double the size of the artery it's arising from should be addressed.
I think, Tim, you measured this and you said this was the same size as the native aorta, correct?
Yes.
It's actually slightly bigger. Yeah, this one's slightly bigger than the aorta. And so the other thing that sort of also factors into her decision, she's not really a transplant patient quite yet. But she is going to possibly need a transplant later on. So obviously that would also add to the risk. She's thrombocytopenic. It's 70 right now, but not too bad.
Another one of the
but
same
that's also
size.
figures
Bring
into
it
our
into the
yeah.
Can you
Pretty
talk
nice.
us
Just
through
Yeah, we can just do packing.
what coil you're using and the size?
So yeah, so this is that was a 6 by 60 in bold. So we kind of like these coils. They're the new coils from Boston Scientific, or newish coils from Boston Scientific. They're nice. They're fibered. They come in very, very long length. So that was a 6 by 60 coil, which is a nice option. And then we're putting this through a high flow direction. We could obviously put this through a true select as well, so you don't really have to think about the microcatheter that we're going
Should
to
we
use.
do another of the same?
Yeah.
Rahul,
Can we
did
get
you
another
mention the
6 by 60?
microcatheter that you're using here? I don't know if I missed
It's
that.
a high flow direction.
Okay.
Yeah, it's a high flow direction.
So why did you
Yeah.
choose that as
So we
opposed
figured,
to something smaller?
Just it gives us more options if we decided to maybe put a plug or something else. We could theoretically do that. So that's the other option here. We could have put an MVP here as well, just to close the outflow and then bring it back.
Great.
But the Embold is microcatheter agnostic, right? So it goes through.
Yes. Yeah. Exactly. So we didn't have to think about which microcatheter. We can use this, and then if we need to put anything else, we can just go to town.
And it's fully retractable, or is it?
Yeah, it's a fully retractable. Once we get this one in, we'll show you how it detaches. It's actually a nitinol push wire, which is nice. So
this is like literally you can't
bend
kink
it.
it.
Yeah.
Can we zoom in?
So you
on
can't
Yeah,
kink
let's
it.
zoom
You
in.
can't.
on the hands?
They wanna zoom
We're
in.
gonna watch you guys deploy it because we want to see the mechanism.
Yeah. No, on Dr. Bishay's hands.
Just to show that it's sort of
Keep going.
hard to kink.
Tim, you have nice hands,
Okay,
but
we
we
can't.
don't want
Can't
to
kick
see yours.
I'll show you when we break it.
So go. Just keep going. We'll
All
do it
right.
when it's closer.
Yeah.
Yeah. Now it's Dr. Bishay's hands.
So Vivian, can you try and or whoever, can you try and bend it?
Yeah.
Or
So
kink it?
so that's your hands. So
Is it still on my?
yeah.
Okay. Yeah. So
Can you move the camera?
Yeah,
this
let's
direction?
center it on.
Yeah, move the
Dr.
camera
Bishay's
towards.
hand.
There we
There
go.
you go.
Yeah. So you can
Yeah.
really go to town.
and I've seen more aggressive maneuvering than that, just to
You have to,
So
you
it
have to
won't-
really
it won't,
try
uh,
to
prim-
do that.
yeah.
Gary, do you
Yeah,
want
I
to
get
tell
the
us a little
point.
bit about your experience with this coil platform and how you use them in your practice?
Yeah, I agree with everything Rahul said. I think the
welcome to
fact
the
that
exercise.
it is able to be deployed, it's microcatheter agnostic, which I like the way you put that. I mean, it really makes it a good tool because you don't have to think about it in advance, right? I mean, a lot of the other coils we have, you have to pair up your microcatheter and your coil and have some advanced thinking about what you're going to use so you have the right catheter in place. With this particular coil, you're able to turn to it no matter what microcatheter you have generally. So I think it works, and I think as a platform
Can we
also
get a 60
for
packing?
the coil, you have your packing coil like he's about to turn to, in addition to a routine fibered coil, as well as a softer coil, maybe for spaces where you want to avoid catheter kickback or anything like that. So if you're used to this coil, there's a whole platform to meet a variety of circumstances.
So, Rahul,
we're going to show you how to
you asked
deploy
for a packing coil, which is basically has no diameter essentially, and it's just a filler
Right.
coil.
So it's got a little bit of a shape to it. It's basically 60 centimeters of soft. It's actually unfibered, but it's pretty good. So actually, we'll talk about it in a second. Here, I want to show Dr. Carlin's going to show how the deployment or the detachment mechanism.
I'm trying
That's
to
over-
get my hands into the,
Yeah.
the field
We're
to
trying to-
show
Can we
it,
center
but
on Dr.
There you go.
Carlon's hands, please? Yeah.
there we go. Perfect. So you can
Tim,
see there are
you,
two little
just
white lines.
Do it over the gallon.
Bring your
the,
hands maybe over
drape?
the yeah.
That way we can see it better.
Yeah. Okay.
Yeah. I don't have a.
Is that as magged in as you can get?
Okay. So we can see
Oh,
the
that's great.
two
Let's go all the
little
way.
white lines here
Perfect.
on the back of the coil, and that's just where you can break the coil, and it's just a string through the inside that's going to detach it. So it's a very easy mechanism to just break and pull,
You don't have to pull the whole thing out. Yeah.
and it's just the tiniest bit to release it. And then you'll see as we come back, that's our end, and the coil stays behind.
Yeah.
So
That's it.
one of the
It's a very
downsides
easy
to using a
mechanism to
packing
deploy.
coil, Rahul, is that the coils are not fibered, right? So you mentioned before
Yeah,
that you were
but it's a
using
little bit-
a 660 in the outflow vessel. Do you think that the packing coil is softer than that coil? Because if you were using, let's say,
Yeah.
a 660, you would probably be able to maybe get a quicker thrombosis because of the fibers, or do you think that it's just a softer coil which allows you to get a denser pack? What's your thought on that?
So this is sort of a different question, right? So in aneurysms, do the fibers count? Because I think classically we have used sort of what neuro uses in terms of packing density, in terms of how much to put within the aneurysm, in terms of how much metal needs to be there. Fibers typically didn't count. I think there's some data from Penn that maybe the fibers do help in terms of that. But I think if you underpack the aneurysm, you still end up, even with fibers, you can end up with something called coil compaction. So I still like to see a dense coil pack with it anyway. And then how many fibers do you need? Sure.
I harping on that packing density point, I mean, did you give some thought beforehand to how big this is and how many coils you might need to fill the space?
Yeah, so I don't sit there with the angiocalc anymore and try to figure it out, but I have a general gestalt of like, okay, how much length of metal is in there, and that how much I'm going to need to really fill this aneurysm. It's 1.5 centimeters, so these are basically 0.015. I think it's 0.15 is the length of the wire. So we're probably going to need probably about 400 to 600 cms worth of metal to close it, at least. So that's sort of how
the length of your microcatheter, because you're from radial, is 155 cm, right?
Yeah, 155 cm. Yeah.
And then the coils themselves, there's no issue in terms of length here.
Rahul, do you want to talk to us a little bit about the choice of catheter? I know that you're using a diagnostic catheter here as an access, but there may be some people in the audience that are interested in if you were going to use a guiding catheter, what choices we have from a radial approach. Do you want to talk a little about that?
Yeah, so that's the other thing. So we talked about this a little bit before we set up the case about using a guide to help. I think I thought if the catheterizations were going to be really difficult, maybe a guide from behind would help, just in terms of not having to pull the wire every time to do runs to figure out where we're going. But you can use a 6 French guide. We have 100 centimeter and 110 centimeter 6 French guides. I think Merit makes a 110 or 125 like Sarah shape. I think it's their Ultima shape guide. Boston makes an FR4 and an MP guide. They used to make a 110 JR4 guide, but I don't think they carry it anymore. I don't know. Are there any more? I think
anything. Well, anything less than 110, I think, can be challenging for a mesenteric guide, especially in a taller patient.
Yeah,
she doesn't seem like
she's relatively short. So we would have been able to get away with it with the 100 centimeter guide. I think anything shorter than 100 in her would have been kind of messy. Yeah.
Is there an FH guide?
There is, yeah.
Nice.
Yeah, that's probably not something. That's not something we would use for this case. Gary, do you want to tell us a little bit about how you would approach this? If you would take a different approach in terms of access?
Well, I mean, I think we're probably mixed with radial and femoral access, but I do find that a guide catheter is not needed for most of these cases. I kind of agree with the approach that's taken here. I mean, for us, we'll use a 5 French angiographic catheter, park it in the celiac or the SMA, and we're usually able to get where we need to go and get the contrast injections that we need through that. So I haven't found it to be too much of a problem. So we're not huge guide catheter users up here.
Yeah.
But I think the approach is a good one here by just using the angiographic catheter, and that's what we would typically do.
I think one of the pluses of using a guide in a case like this is you could actually do angios behind your microcatheter to make sure that you have complete occlusion without having to remove your catheter and lose access, essentially. But outside of that, I don't see a huge benefit, and I think this case demonstrates that it probably can be done without a guide catheter.
But the truth is, right, he's going to fill the space, and he might even have. I would imagine you'll probably stop when you see a little bit coming into the proximal vessel, so you know that you're out of the aneurysm. Exactly. And the truth is that you're kind of done anyway. There's not much more you're going to do other than put some coils.
Yeah, and the other thing with the packing density is a little bit off, right? Too, is because we're going to close the inflow and the outflow. So, do you need to really pack it as dense as you would if, say, like a renal aneurysm where it's sort of like a side, off the side,
Yeah, so Rahul, just in terms of strategy, to summarize for the audience, you used fibered coils for the outflow and probably the inflow, and then you used soft packing, which don't have fibers, for the aneurysm sac itself.
Yeah, again, we would have, if we couldn't get into the outflow or the 6 just kind of stopped right there, I think what we would have done is used, and bolts come in like these 22 by 60, I think 32 by 60. We would have done the frame and pack method, but the 6 kind of fell in, created a decent frame for us. I wasn't really worried about it going anywhere, so we just started packing it.
So how many coils is this so far, Rahul?
So that's three packings, and then the 6 by 60. So we're at 240. So probably can we get another 60 packing? I think it's going to take it. Yeah. If not,
do you think this Embold platform allows you to use less coils, Rahul?
It does. It also, I think, it makes the cases go faster. Look, I mean, there are other coils you could use. The penumbra coils are nice as well. They're a bit more, for us at least, they're a bit more expensive. So that would have been good. I think the older interlocks, you can use them. We've all had issues with like the hooks and stuff. I think for bigger aneurysms, it's kind of annoying. They're a bit stiffer. The Medtronic coils would also work, but again, they're a little bit on the smaller side, and their size matrix isn't as great. And same with Terumo, I think I have the same problem. And then for aneurysms, I'm not a huge fan of having to use the electrolytic detachment just because it just adds more time and cost to the case. So you can see this packing coil. They're very, very soft. Yeah, you can see it just sort of filling in the spaces and stuff here.
I agree. They find their way into the gaps in the coil pack. I think they do a great job, accomplishing this goal here.
And just to let the audience know, I mean, it looks like Tim, our chief resident, has been pretty much releasing the coils for all of them, pushing and releasing. Is that correct?
Yeah, exactly. Yeah. So I'm not really
independently
here. I'm not really doing a whole lot of work here.
So are
you
you
see
guys
what Tim's doing is basically
you're just waiting you're trying to pack this in towards the origin of that aneurysm, and it looks like you guys are almost done. I don't know how many more you're going to get in there.
Yeah,
and then put a couple into the origin, and that's it.
Tim, I just noticed you didn't like the way it was packing, so you retracted it and then resent it.
Yeah, exactly. And I think that's
good.
Go a little bit more, right? You're a little just
out. Don't you guys also find that once it's in the body for a little bit, it behaves differently, right? It doesn't behave
exactly.
the same way the first time.
Yeah, exactly. So as it warms up to body temperature, they do get a little bit softer, or for the shaped ones, they do get their shape a little bit better, So what do you think? Another
this is what I mean right now, right? You don't necessarily need to do a contrast injection to know that you've done a good job here.
Yeah, I agree, Gary.
Exactly. And I find that
also naturally backed you out. You probably aren't going to be able to get, I don't know how much a guide really helps inform anything here.
Yeah. And then in terms of the packing density, I feel like I got enough coils in. Like I'm about that 300, amount of coils in, and then we're going to close the outflow. So can we get a 620?
This was four packing, 4 60-centimeter packings that you put in there?
4 60-centimeter packings and then a 6 by 60 that sort of created our frame.
And then how much running room do we have to the?
We have a decent amount. Yeah, because it's
that entire
segment there. So that's the one place where the guide might be.
Rahul, you asked for a 6 by 20 fibered coil here. Is there a reason you don't want to put a 6 by 60 just to sort of decrease the number of coils you might need on the inflow?
It's not that much length.
Yeah, we don't have that much running room before we hit the SMA.
Yeah.
Do you guys want to put up that run just so we can take a look? I don't think we can see it, but I want to just take a look just to see what that looked like.
So this microcatheter run is basically right at the edge of where the aneurysm is, and then let's see if I can go to the SMA run. Yeah, so you can see, but it's basically that first branch going to the left, right? So it's not a ton of space before we get into the SMA.
The advantage, not necessary, but the advantage of a guide cath system here is that you can repuff or angio with your microcatheter in place to see exactly how much running room you have here.
I think right here that would be the difference.
Yeah.
This aneurysm doesn't. It's an aneurysm of the collateral circulation, so it doesn't feed any distal bowel branches, correct? And I think when you present this as an SMA aneurysm, it's a little bit of a misnomer, right? Because it's more of a maybe an IPDA aneurysm or something along those lines.
Yeah.
Agree.
Exactly. Yeah. It is an IPDA aneurysm, right?
Yeah, I think in our experience, almost all of these IPDA aneurysms that we see, probably near 100%, are related to celiac stenosis or median arcuate.
Hey, Rahul,
so is this a 6 millimeter coil?
Yeah, 6 by 60.
I think they said it was a 620. Yeah.
Okay.
Or 620. Sorry, 620.
Let the audience know in terms of how do you size your coil for the inflow outflow? Do you go to size?
Yeah, so it's supposed to be 20%, 20 to 30% oversized. I mean, we're obviously not really sitting down and measuring the arteries sizes here. That's probably good. But yeah, about 20% oversizing. In terms of the length, it's sort of a guess, right? Like you kind of look at what the last coil did and then go from there. So maybe put like a smaller one, like a 4.
Yeah, I think we can still fill
so we're gonna
that space with the same length, maybe. But
what if you take like a 420 or something like that? Put that inside that gap.
Yeah. Exactly.
It's interesting. I asked about the coil size because I was thinking to myself I might have gone smaller.
Aneurysmal.
It looks like it's a little bit oversized, right, Gary? I think a 4 or 5 filling the gap would be better.
Yeah, so we're gonna use a 4 by 15 fibered coil to close. They do come in softs as well. I'm not a big believer in the soft coils. I know like Aaron uses them for prostate sometimes, not anymore, but
yeah.
Well, when you use a soft coil, it's probably better in smaller size vessels, maybe 4 millimeters or smaller. I find them to be really helpful in like the 2 to 3 millimeter size, and so that's probably a much more appropriate vessel size than what this is.
Yeah,
I agree. We like them for trauma. We like them for small vessel trauma.
Yeah.
And we haven't commented yet.
Yeah, I mean the trade-off obviously is that unfibered.
Yeah.
No, I'm just saying.
Sorry, go ahead, Ed.
We haven't commented on what Tim has been doing in between coils. He's been flushing the microcatheter with saline just to keep it.
Yeah, that's the other thing too. Again, for these longer cases, some people hook them up to a TUI and then a side flush to continuously flush the microcatheter, but every so often just to flush it. With the bigger microcatheter, not as much of an issue. Yeah, you can see the 4 just sort of chews up all that space pretty well.
That's very nice. It's packing quite nicely.
Yeah. I think that's probably where we're going to stop. Yeah. So for this one. Yeah, so again, for the bigger microcatheters, probably not as much of an issue. So we're going to just pull it back, I guess, and then we can maybe just do a puff from below.
How hard was it to cannulate that artery? Was it a challenge to get to that branch or easy?
No,
so you could probably just remove the microcatheter and do an angio through the guide, right? Yeah.
Yeah. Yeah, I think that's actually
that's out.
That's out. Yeah.
That's out. Yeah. So why don't we just pull it out and just do a run?
You can also look at it in multiple views just to make sure that you don't have areas that aren't filled, though it would probably be.
Although I'm not sure what we're going to do.
No.
Yeah. I mean, the other thing is, now that we have liquids available and stuff, you could theoretically. I mean, here we didn't really need it because it didn't take a ton of coils in terms of the number of coils to treat, but we could have used lava or maybe to fill in some of the gaps if it was like a really big aneurysm, or if you felt we couldn't get back in.
I think warrants a little discussion because I find at our place we really quickly have started to think about liquids for so many of these types of cases, and my quick back of the napkin calculation is that was less than 2 ml of volume in that aneurysm.
Yeah.
And so, there's a little part of me that wonders, could you have put a distal coil just as a backstop and then filled that space? And you're dancing around a 25% packing density target roughly, and, less than 2 ml would give you close to 100% packing density. So does that enter into your thinking about how you approach these cases?
It does now, right? Because it wasn't really an option beforehand.
Right.
So yeah, it definitely does now. I mean, I think we've sort of reserved it more for even bigger aneurysms, not so much the 1.5s, but for like bigger splenics and things like that. But yeah, I think as we get more experience with it, I think it's definitely going to change how we do these cases. So you can see the aneurysm that we treated is occluded. So now the question is, this went pretty smoothly. So I think we're going to try and go after the second big one here and trying to figure out where it's feeding.
I think those two are both coming off the same.
Like they share,
potentially maybe.
So we're gonna.
One thing I wanted to mention,
into...
based on what Gary was saying about putting liquids in after you've occluded the outflow, you do have to be really conscious of the fact that the outflow is occluded, because some of these liquids, in particular, Obsidio, can go through the coil mass, and we've seen that a couple times where it can actually shear a little bit in the coils and go distally.
And it's hard to see. It's hard to see fluoroscopically, even though you're doing that.
Yeah. So you could be almost sure that you would be able to get it to stay in the aneurysm, and it may not stay.
I think it's going just slightly.
Yeah.
To the left and then coming across.
Yeah. Just so everyone knows, though, that would not be. That's not what Obsidio is indicated for. It's for bleeds.
Right. That's off label. Yeah. Actually, technically speaking, it's off label for lava as well, right? But yeah.
This I think this angio shows quite well the collateral pathway, so that the celiac collaterals are intact.
That's still
And there's so many too that even if you take out those two aneurysms on the right side there, it's not going to affect the collaterals at all. Really, the ones going north on the left side are patent.
Yeah. I was asking about the liquid before because we tend to be thinking that, but I think in this particular case, I might have gotten a little nervous with the relatively short amount of space between the SMA and the aneurysm. I would have worried about reflux there. So I don't know if that would have been the best case there to talk about it, but something to think about now.
Yeah, I think it's actually really relevant in a case like this, because if you're in a splenic aneurysm, your distal embolization is not going to have too much of a detrimental effect if it migrates distally, whereas in the SMA it could be worse. So I think it's important to think about what vascular territory you're in if you're going to consider something like that.
You're leading with wire.
Looks like you're in it. No, no.
Nah.
Let me get to you there, maybe.
So are you guys in AP right now, or are you angled a little bit?
Yeah, we're in AP.
That might be it.
There it is.
That's not it.
No, that's
a different one. It's like.
What wire is this? Is it 016 fathom you're using?
It's just a 016 fathom. Let's see. That's into that aneurysm.
Like, watching water boil.
Yeah, exactly. There we go.
There it is.
Oh, nice.
Yeah.
Stop here.
Yeah.
If you can go out. Looks like it's coming off securely.
Hypothetically, let's just talk about a case like this where you can get into the aneurysm, but you can't get into the outflow. It looks like that. It looks like they're connected.
They are connected.
They're two of them are connected.
Watch
so
your
you're going to probably you're going to be able to embolize both in the same session, which is great. If you were unable to get into the outflow, Rahul or Gary, what would you do?
Yeah, go ahead.
There are some situations where you can't get into the outflow.
You done?
I would probably think about letting the coils do the work for me.
Yeah.
So I think I would put a larger coil in. I kind of create that frame within the aneurysm, and then start using softer coils and allow them to kind of buckle their way into the outflow. That will work a lot.
Yeah. Or if you packed it so densely that there would be no pack filling.
It honestly probably doesn't matter. If you do a good job with the packing, it's not going to matter.
Just shove this hair further.
Agreed.
Right. Oh, maybe not straighten it out, right?
I would imagine in that situation, the coil packing density is much more relevant than it would be in a case where you can do both the inflow and the outflow.
There we go.
Yeah.
There we go. A little bit of work here, but I think that's all we need, right?
That's all we need, right?
Yeah. Let's make sure this doesn't kick us all out.
The only thing I was thinking was...
So
I mean, here in this case, the high flow.
Yeah.
Yeah. Yeah, the high flow is probably not the best choice here for this.
Yeah.
Yeah. Although I think,
Track's fine.
I mean, I'm not sure if we're supposed to say, but I think Boston's supposed to be developing a high flow TrueSelect.
It tracks fine. The what do you think the diameter of the outflow vessel is? 4?
That picture.
Yeah, this one's smaller than the previous one.
So, yeah, what do you guys think? 4 or 5?
Yeah, 4.
I'll go 4.
Can we get the?
Can we get
a 415?
Are you getting nervous though about that taking out the second source of supply to the liver? Just out of curiosity.
I'm not. So if you go back,
Aaron pointed out that very robust, more medial,
the pancreatic I mean, I'm doing this.
Yeah, you can see the alternate pathway on this angio actually.
So you can see the gastropaploic here. You can see the GDA, and then on that image, it's
there. You go, right there. Yeah.
The one that goes straight up. Yeah, that connects right over to there.
It's kind of the one right in between the aneurysm and the coils. That one. Yeah.
Yeah, exactly. So I'm not terribly worried here.
Would you continue to perform surveillance on this person?
Yeah, so I guess
for
that's a
the
good question. So
development of
how do you guys follow these? So,
Actually, two
given the
pathways.
metal and everything.
Mhm.
I would probably
It's-
follow these with MRI personally.
Yeah, an
Yeah.
MRA,
Yeah.
you can does a good job.
I'm not sure we actually
Yeah,
get the
I
second
agree.
aneurysm here.
Yeah, I don't think so either, but we'll see.
So
but yeah,
what
I think
coil do you have
we
here?
would do. So this is a 4x15. Excuse me, trade back stuff, and you can see the coils are taking these turns fairly straightforwardly without too much issue. Okay, yeah.
Yeah, I'm just gonna kind of let it go and then.
Yeah.
Now, just more of a technical note. Would you think about reducing your microcatheter in that aneurysm sac, or do you like to have it coiled?
Sorry, excuse me.
outflow?
We tried. You can pull the microcatheter back, right, a little bit. We tried and it wouldn't reduce. So.
Okay.
Yeah. Yeah.
That 4
I
looks
don't
like
mind
the right size here. I think it's
Yeah.
perfect.
Nice.
Yeah.
I don't personally mind having it loop in the aneurysm. I think it allows for better coverage as you pull your catheter back and put some more coils in.
Yeah, I agree, Gary. I think that's a good point. I don't think it makes that much of a difference. I mean, you're not placing a large device here. You're just putting coils.
Right.
No, I think it naturally just reduced anyway.
A little bit. Yeah.
It was just hard to push.
Yeah.
See the Sarah.
Yeah.
Take
Oh no, yeah,
multiple
it's still
turns.
looped on itself.
Perfect. So do we have another 6x60 packing coil? We're just gonna sort of pack our way back, I guess. Yeah.
Do you feel that the packing are softer than the standard Embold, Rahul? I think that I get the sense that they are when I use them, but it's probably just because they're not fibered, right?
Well, I mean, it's basically a longer, slightly larger version of their packing. No. Yeah, that one's 60. Yeah. Yeah,
do you like your choice of microcatheter here, or do you think? I mean, we talked about using Embold and having the ability to use 021, 027, different types of microcatheters. Yeah. Do you like having a high flow here? Or do you think it's?
I think if we were going to get, I think if these were more difficult to get into, I think the high flow is nice because you can get a good robust run through the microcatheter. If we were going to get lost, so I think we were ready. If we couldn't pick it off or it was too difficult to catheterize, then I think we were ready to use sort of a low flow catheter. Probably would switch to a true select.
Yeah.
You might appreciate it here. I think you'll appreciate it here as you're in that more distal aneurysm. You might want to do a contrast injection to make sure you're okay before you buckle into the first one.
Yeah.
And in terms of, PSI, the direction is a 1200 PSI, whereas the True Select is 800 PSI. And then here you have a 2.7 French, right? And then with the True Select, it tapers down
You're able to reduce
at the
it a little
tip
bit.
to a 1.9 or 2.0 French.
Yeah.
The other thing to keep in mind is that there's
nice
trade-offs with the True Select. The tip of it is quite soft, and so some people will complain that it kicks back during coiling or during power injections, but that's how it's built. So you have to be aware of that when you use the True Select. It's not. I don't think it's a deficiency. I think it's just so that it wraps around and gets very selective into vessels, whereas the direction has laser cut nitinol throughout the microcatheter, so it's quite stiff at the tip.
This is incredible how you basically coiled that entire aneurysm with one coil.
Yeah, it's great.
So I think there's a second. You may have to pull it back.
Yeah, and you're prolapsing.
It's trying to go.
Second outflow.
There's a second outflow.
Yeah. There's an outflow on the top of that first aneurysm there.
Yeah.
And it looks like it's prolapsing into that, which is probably
that's okay.
Not,
you can let it prolapse.
It's probably fine.
Yeah, it's not the end of the. Yeah. And then
so Ed, just to hit back on your point about the True Select, I don't think you'd use it in a case like this, right? It's a great catheter, but you're generally using it to take advantage of its trackability going out real distal.
Yeah.
So by definition, you're almost in smaller vessels anyway, so it's fine. It's great, actually.
Yeah.
When we used to use interlocks in these high flow catheters, we would have a very difficult time pushing them through. They were really not intended to be used through an 027 catheter.
I did, but it,
this coil platform is great because you don't notice a difference depending on which catheter you're using, which is great.
Yeah, it's a remarkable bit of engineering because you'd think it would be too small for one catheter and too big for another, but it seems to be fine in both.
Yeah.
Yeah, so here's where we get a little problem. So we pulled it and the pin wire broke before we could pull it. It was weird. I don't think I've ever seen that one.
I've seen it once, but
How'd you guys manage it?
we cut it.
Cut it?
Take some force, but
Cut it here?
yeah. Cut the pin again.
This is great to see because, if you're using a lot of coils in a case, 10, 20 coils, there's usually a couple coils that don't deploy exactly the way that they should.
Yeah.
Do you think it's detached already, or?
If
we tried.
You can just pull it, but otherwise you can just pull it out.
Yeah. Yeah, we can just pull it out if it's.
Yeah, I see.
Was this the 60 packing?
Yep.
I think this was the 60
Yeah, the
packing,
packing.
which is basically filling that entire aneurysm there.
Oh, that's weird. It's like there we go.
Nice.
There we go.
There you go.
Success.
Success. Okay.
You just have to knit the sweater a
you
little
have to
bit,
push it.
and you're good.
Yeah, now it's off.
Okay.
Yeah.
Good.
So I think now we got to figure out where we are exactly before we start putting more
Yeah,
coils.
I
I think
think
we've
you need
flopped.
to-
Side the first aneurysm, yeah.
You're in
Yeah,
the
but
big
let's just
aneurysm,
get
I
back
think.
into
Rahul.
it.
Yeah.
Agree.
But just at the origin of it, maybe get
Yeah.
back in a little bit.
Go run.
Better
Now
to
you're
be
happy you
safe
have
than
that high
sorry,
flow.
just puff, yeah.
Yeah, now exactly. So we have the high flow.
You can see the pulsation.
We'll just
in
do a
the
run.
aneurysm.
Oh, actually, you're looped on yourself.
Yeah.
Are you? Yeah.
Yeah, you're looped in on
Okay.
yourself.
There's actually another outfit.
So you want to take like I think we're maybe out of 60 packing coils. So maybe you want to try like I think.
What if
maybe
you
like
take
an
a fibered
8 by
60?
6?
You take
Yeah,
a
that's what we're
fibered
gonna try and
60,
do.
like
Do we have
an
another
860?
660?
Yeah, something like that. It probably doesn't matter at this point what you use.
Oh, we do have more 60 packing. Okay, so I guess we actually do have another 60 packing. So we'll take a 60 packing, another packing coil in here, and just fill it in, and then maybe try to. We have a little bit of length, so we can close the outflow if we have to. Yeah, but I think after these two, I think we're gonna stop, and obviously we'll do a run. But I think this is sort of all we wanted to treat today.
Yeah, it sure looks good.
Um,
You got all the
Oh,
aneurysm.
it looks great.
yeah. So
I don't
Gary,
think there's
again,
anything
I
else
think
to treat.
yeah.
Right?
Gary, it's great to have you for today. Do you want to talk a little bit about Jest, because it's coming up next week, right? So what can we expect to see at
Yeah.
Jest this year?
Yeah, I think conversations like we're having, I think really to me is what highlights the guest meeting over other things that could take place during the year. We do the deep dive at guest into all the embolics that are out there, what applications you might use them for, how you use them, how they're different from each other. So I think the conversation here has been a real life application of the things we talk about, both at the tabletop and in various lectures during the course of a 4-day meeting. So if you're into embolization and you want to really drill down on the different tools that we have, it's a
Not gonna take it
a
off
great
the
place
roadmap,
to spend
yeah.
a couple of days. So it starts this coming Thursday down in New York City at the Sheraton, just down the road from you guys.
Yeah, it's always a great meeting. We always learn a lot from that meeting, and it's great to see people from outside, even outside the U.S., how they handle some of these complicated cases. Obviously, they have tools that we don't have or don't have yet. It's always great to see, hear the discussions.
Yeah, this year we're going to focus a little bit on some of the neuro tools that we have, because I think a lot of peripheral
nice.
interventionalists don't take advantage necessarily of some of the stuff that's maybe our colleagues down the hall do.
I have a hypothetical question, Gary. Before we had detachable coils, did you used to do these cases with pushable coils, or can you think of cases where you would do a case like this, complicated like this, where you would use pushables?
Yeah, we used to use pushable coils, but fortunately, I'd say it was about just a couple of years into my career when interlock came out, and it kind of changed the game.
Yeah.
So I think it's great to say. I love when people say I only use pushable coils, but the reality is that you can't get the packing density you need with pushable coils. You're at the whim of what the coils want to do, and at least with all these detachable coils that we had and now have we can kind of tell them what to do and how to behave, but you can't do that with pushable coils.
Gary, I
So,
apologize on behalf of our group for Aaron.
Yeah, that's all right.
Instead of asking like Rahul or myself that question, he just went right.
I have enough stress having just turned 60. I don't need Aaron throwing it right back at me. So
Yeah.
I still use pushable coils, but not for something like this.
Yeah, but you get people that stand up there and they say, I only use pushable coils, and they, banging on their chest saying they only do that. Quite frankly, you don't think it's not possible to get this result that you got here, just looking at the image that we're seeing here with pushable coils. You just can't do it.
Yeah, I agree.
Sorry,
I mean, you're almost done, it looks like, and you've coiled essentially 3 aneurysms and 3 separate outflows in less than 30 minutes, it seems like.
Yeah. Very efficient. We always try and, as a hobby, try and look and see if there's some type of figure or shape we can tell from the coil mass. I've been trying to figure this out. Maybe
an octopus?
Yeah, that's what I was thinking.
Yeah.
Lacking legs. All right.
We've seen horses. We've seen other things.
So it looks like you probably just need maybe 1 more coil, and then you're probably done, right?
I think so. Maybe something that'll prolapse into the inflow here, and then call it.
Yeah.
The inflow.
Be a 4 or 5.
You would estimate it's a little smaller, so maybe a 4 would be good.
Yeah.
5, yeah.
Hey Tim, have you ever used a pushable?
I have.
You want to do like a 415
with
the
Aaron,
inflow?
although certainly not for something like this. I've had the hazing of firing in the pushable with the 1cc medallion and all
nice.
of that.
So you have used a pushable.
But I will say these are probably the ones that I've used more than anything else, including interlocks.
Are we at the
inflow coiling portion? Yep.
Yeah. Okay. Cool.
Do you want to puff it, or you want to just go?
Yeah. Let's see. I think I'm still in a loop, although not that we can see that, but I'm gonna DSA it because otherwise we're not gonna see.
What do you guys think about microcatheters that have different markers on them for aneurysm coiling? Obviously there's some that have a distal marker and then a proximal marker that help you identify the tip.
Oh, I think you're actually.
I don't personally think they add too much, in my opinion, at least.
Yeah, I agree with you, Gary. I think sometimes you're just so deep into the aneurysm that you're not gonna even visualize that second marker anyway. The collateralization in this patient is extremely robust. It's a great example of how when you have these celiac stenoses, how robust that circulation is.
Well, and it brings it around to the first question that you guys were asking, right? I mean, it shows that you don't have to think that much about taking out vessels in this area.
Yeah.
Yeah.
So what do you have here? What coil is this?
This is a 4x15, and
fibered.
It may not be quite. Yeah,
fibered. Looks like there's still some room there.
We saw that space on the inferior aspect, so.
Yeah.
No, I think it's starting to poke out into that inflow vessel. I think you wouldn't have gotten away with the packing there. I think it's a good choice.
Yeah. Maybe a 5? What do you think? 520? Do we have 520 or is it 515? I can't remember.
I don't know. Do we have like a 520 or a?
So can you talk to the audience in terms of how do you know where the tip of your microcatheter is in the coil mass?
It's
a great question.
It's deep in the aneurysm sac here.
Well,
I mean that's the other thing. We could pull back a little bit on the microcatheter, and then coil more.
I don't know. I personally, I like where it is. I think you do those contrast injections to figure out where the tip isn't, right? So you don't necessarily need to know. You know it's somewhere in the aneurysm. If you start pulling it back into the feeding vessel, now you're limited a little bit in what coils you can put in there.
Right.
Because you'll kick back out.
I agree.
You may not get back in, into that spot. So.
Yeah, we know for sure eventually this is going to prolapse me back into the inflow.
So this is a 5x15, so figure maybe a little bit bigger might push us back.
Yeah, I mean, the nice thing about these soft coils is that you're gonna push yourself back when the time is right. If you have a stiffer coil, you may not get that packing density before you push yourself out of the aneurysm, and that sometimes can lead to recanalization.
I like to actually use the coil when I get resistance as a wire and then pull the microcatheter back slowly over the coil.
Right.
That looks really good. I mean, there's not a lot of room left in that aneurysm, I don't think.
No, I think this may end up just being the last coil, and we're gonna. There's always
It's almost like there's
more. You sound like one of my reps now.
You can do one more, right? There, exactly.
I would do one more, Gary. I agree. One more coil.
Okay,
I think we're done.
All right, can we have one more 415?
It's pretty dense.
Yeah. It looks amazing.
But it's almost like there's an infundibulum going into the aneurysm, right? That's what it almost looks
Yeah.
like.
Yeah. Yeah, let's see. And we're just going to do a little swing by and see.
Mm-hmm.
Yeah, that's not really super helpful.
You see how the view is important, right? Because that really, you couldn't see that as clearly.
Besides the cocktail in the radial artery, you guys haven't used any heparin, correct?
Nah, we haven't used any heparin. Turn up the juice a little bit here. It's kind of lateral. Yeah, no extra heparin, just our radial cocktail, which is 3,000 of heparin, 2.5 of rapamyl, and 200 mics of nitro. I got it right this time. Yeah, we don't really redose, and then we'll just put the band on at the end, and she'll send her home. Yeah. Hard to push, Tim?
A little bit, not super. I'm just gonna let it kind of.
Yeah. Yeah, as Gary said, sometimes you just kind of let the coil do the work, right? So give it a little space, and it'll kind of find its place here. Yeah, I think now we see the tip of the microcatheter, right?
There it is.
Yeah.
Perfect.
That looks great.
There it is.
Yeah. Maybe we'll do a puff in this sort of projection.
Yep, and then we'll look for the final angio. Yeah, it's a great result.
Yeah. I didn't even do anything. It was all Tim and Vivian here. So. Run.
Sometimes when your catheter is right up against that aneurysm, you get that's great.
All right, so let's
that's a good point, right? I mean, you want to see the picture, but it's nice to back your catheter away a little bit, because I think sometimes you get fooled.
Yeah. Let's take the microcatheter out. We'll just do it to the Sarah now.
Okay.
What vessel was that went off to the left there? Was it, it's a named vessel?
You can name it if you'd like.
Can
we hold respirations, please? Okay. Yeah.
That's good.
So,
can you guys tell us your fluoro time and your dose? Because this is our new Phillips room.
Yeah.
I'm sort of curious as to what the dose would be here.
Our total fluoro time was 19 minutes, and the DAP was 89.6 gray per centimeter squared, and I think total dose was 869 milligray. It's a very low, for what we did, very low dose. So here, I think we had a great result, right? I think the aneurysms are all occluded. There's still robust flow back to the celiac, no issue. SMA is still filling well, right?
Agree.
Get into the SMA itself, but yeah, the SMA is still filling really well, and I think we're going to get out and be done.
Perfect. Great result.
Looks great.
Yeah.
Thanks for presenting this great case, Rahul, Vivian, and Tim.
Thanks, Gary, for coming. Yeah.
Thank you, Gary.
Oh, my pleasure.
We look
great
forward
discussion. I appreciate it.
to Jess next week. Very excited for that.
Yeah. Look forward to see you guys.
And we'll see everybody back here in June, the second Friday in June, for our fourth case. So thank you everybody for watching, and we'll have this up on YouTube very shortly.